Good evening, everyone. Assalamu alaikum. Welcome to IMIC Live. This is the webinar, as you already know, on new treatment options for benign enlarged prostate and prostate cancer without medicine or traditional surgery. This webinar is jointly organized by International Medical Information Center, IMIC Limited, and Fair Park Hospital, Singapore, to create awareness to lead healthy life. Prostate cancer is the number one cancer by incidence in male of increasing age and second by mortality throughout the world. According to a source, adenocarcinoma of prostate is the most common form of cancer in men, 25% by incidence and second by 10% mortality throughout the world. There is 1 in 6 lifetime probability of being diagnosed with prostate cancer in men. So before starting our discussion, let me give you a brief information about Fair Park Hospital, Singapore, which is a private tertiary healthcare institute, focuses on delivering acute and clinical care as well as managing chronic conditions in patients, supported by a team of nurses and allied health professionals. Fair Park Hospital specialists provide treatments that are integrated with medical technology as well as services that attend to a patient's entire journey. This hospital is architecturally designed to use the landscape and surroundings of Singapore's iconic Fair Park location above the Fair Park Mars station, and the vision and the mission of Fair Park Hospital is focused to bring value to people through solutions for holistic healthcare, hospitality, and wellness. Please join the live session and ask any of your queries and do share us your valuable comments. Thank you for joining with us. Let's get introduced with our today's panel of experts from Bangladesh and Singapore. First of all, I'd like to introduce with our very honored and honored doctor, and we are extremely honored with the presence of Professor M.A. Salam, founder, president, and CEO, Urology and Transplant Foundation of Bangladesh, UTFB. He has extensive experience in the field of urological cancer. Just for a brief note, he had his FICS from International College of Surgeons, USA. He was the chairman of Department of Urology, BSMMU. He also joined to the Institute of Urology, London, UK for 2 years of WHO fellowship program. His current interest concern about the prevention and management of due cancer, which includes adrenal, kidney, bladder, prostate, testis, and penile cancers. Thank you, sir. Thanks for joining with us and for your time. Today we have also a doctor from Singapore Fair Park Hospital, Dr. Chong Kian, Senior Consultant Urology, Dynamic Healthcare Innovator, Researcher, and Educator from Fair Park Hospital, Singapore. He is a certified urologist who manages both general urology and complex urologic cancers. He is a specialist urology surgeon who is skilled in traditional open surgery, advanced keyhole laparoscopic and endoscopic surgery, as well as the modern Da Vinci robotic surgical systems. Dr. Chong completed his full-time advanced clinical urology oncology fellowship at the prestigious Memorial Sloan Kettering Cancer Center in New York. His key professional expertise includes the diagnosis, treatment, and management of prostate, kidney, bladder, testis, and penile cancers. In the Singapore Cancer Society, he was an advisory panel member to improve prostate cancer awareness and supervisorship. survivorship. So, and I'm your host, Farzana Wali Liza, Chairman, International Medical Information Center, IMIC, which is affiliated with Fair Park Hospital, Singapore. So, we'd like to first start with Professor M.A. Salam, sir. Thank you for your time, sir. During your years of experience and as a researcher on prostate cancer, we'd like to hear from you, sir, considering Bangladeshi patients' perspective. Usually, in what conditions, in what stage patient comes to you for the treatment, and the treatment options and prognosis in Bangladesh. Please, sir, over to you. Thank you, sir. Can you please unmute yourself, sir?
Thank you very much for this brilliant question. I believe that the prostate cancer is somewhat a very mysterious disease in this part of the world. In the entire Asia, we thought 20 years back that the prevalence of prostate cancer is very small in this country, so we need not to spend much interest in this. But as the time is passing, as the urological service is expanding, as the life expectancy is increasing, even in Bangladesh, which is about 72 for the male and 73 for the female. So it is a it is a male disease because prostate is only male is having the prostate. So cancer is also only having by the male counterpart. So we thought that it's a rare disease, but as we are improving our services, we found that it is more common than what we thought. 20 years back, it was almost like this. All the patients were presented to us in an advanced case. Most likely the bone metastasis, pain in the bone, and etc., or a pathological fracture or something like that. But nowadays, the scenario has been changed. We are getting more and more locally advanced cancer and the organ confined cancer, which can be cured. Prostate cancer is one of the cancer which can be cured if it is detected early and if it is localized inside the prostate. If you can remove the prostate or if you can burn the prostate with radiation therapy, possibly you can have a cure. Nowadays, even if it is invading in the local structure like seminal vesicle or in the adjacent structure, it can be subjected to surgery plus multimodal therapy in the form of radiation therapy or androgen deprivation therapy. All these things actually, when combined together, this will lead a curative outcome. Not only that, the prostate cancer nowadays we are recognizing that many patients are coming with small metastasis, means one or two places in the skeletal region. We consider it as an oligometastatic status. Oligometastatic disease of the prostate cancer, although it is spreaded disease in the outside the prostate, but still we can cure it with the help of multimodal treatment, maybe combined with radical prostatectomy or radiation therapy and complemented with androgen deprivation therapy and also the radiation therapy when it is required. For the metastatic side, the radiation therapy can be given. So all these things can actually, we are doing as a protocol, we are treating the oligometastatic prostate cancer. So these are the presentation, usually the early, locally advanced and oligometastatic. But many times we are confronted with the very advanced prostate cancer, which requires huge treatment with the ADT, with or without chemotherapy. Nowadays, varieties of androgen deprivation therapy like LHRH antagonist are available, and it is predominantly being used. LHRH agonist is also used, and in addition to ADT, we are using the abiraterone acetate, which is prepared in this country also by one pharmaceuticals, and enzalutamide and apalutamide is also being produced in this country, or it is available from the international sources, mainly from the India. Many drug comes in the market. So all these things make it possible that we can treat most of our patients who are having metastasis, and particularly the huge metastasis, bulky metastasis. Some of the patients are presented in when they are treated elsewhere with incomplete treatment. They many times they are presenting as a castrate-resistant prostate cancer. So those are difficult areas. Castrate-resistant prostate cancer is not very easy to treat, and their outcome may not be very good. So all our effort is spent to not to allow the patient quickly to the CRPC status. So if we can keep the patient in the primary treatment, then possibly the longevity of the metastatic prostate cancer can be achieved. So this is our presentation and what we do. But there are many other issues. If you feel like, you can ask.
Thank you so much, sir. I mean, that's really good news for us that the advancement is going on here in Bangladesh, and also due to with your all treatment and research, there will be lots of more options here in Bangladesh will be introduced very soon. So now I'd like to go to Dr. Chong to hear from him about uh, basic information about what is prostate cancer and the new treatment options we have in Singapore for benign enlarged prostate and prostate cancer. Over to you, sir. Thank you.
Thank you very much for inviting me. And Prof. Salam is a very well-respected and very experienced urologist. All of us in Singapore love him. And I also sometimes learn from him. And all the experience that he has teach me all this while. I also see quite a similar path where more and more prostate cancer is being seen also in Singapore, just like Prof, just like in Bangladesh. In fact, last month, Singapore Cancer Registry report, now prostate cancer is number 2 in Singapore now. First time in the whole history of Singapore. It's going more and more higher incidence. Now it's number 2 now in Singapore. First time ever. So we'll have a lot more prostate cancer, similar, Prof, to what you see in Bangladesh. And during the diagnosis, more and more patients are found in the early stage. So we must learn how to manage them, cure them. It's a difficult problem because we know trying to cure them sometimes can cause side effects. So this is something we all have to learn how to balance. So for my talks, I will share into 2 separate parts. The first part is about benign enlarged prostate, which is not cancer. The second half of my talk, then I'll talk a bit more about the new treatment for prostate cancer. Prof, if it's okay, I will share my slides. Okay, now I'll share my slides. Okay, Farzana, are you able to see my slides?
Yes, yes, we can see.
Thank you. I will be keeping it in this view because I'm going to play some video, so it may be a bit smaller. So I'll keep it here. So my talk is going to be on new treatment for benign enlarged prostate and also prostate cancer. If you want to take a picture, this is the way to contact me, both my website and my email, or just simply type my name and Farrer Park, you'll be able to find me. Today's talk is going to be on 2 different parts. First is the treatment of BPH, which stands for benign prostate hyperplasia. I'll give some of the new treatment available in Singapore. After that, I'll talk about the new treatment for prostate cancer. BPH, which is benign prostatic hyperplasia, we know is the bigger size prostate that's causing the blockage of a urine outflow. So I understand in the audience, some are doctors and some are not doctors. So forgive me if I give something a bit simple as well for those in the public. Normal size prostate is the size of walnut. It's just below the bladder. So every time our bladder squeeze, it has to go through the middle of a prostate to come out. But when the prostate gets bigger, sometimes as big as a lemon, it causes a blockage along the path. Some of the signs and symptoms for BPH for men, when we grow older, in Singapore, a lot of men after 50 years old start to get these symptoms. Number one, we can have weak urine stream. That means the urine doesn't flow so far. We can go to toilet often and sometimes dribble on our underwear after we urinate. And we keep wanting to go to the bathroom. Sometimes it can also leak urine, and even at night, we can't sleep well because we go to the toilet more often. So these are some of the possible symptoms of BPH, which is the benign prostate hyperplasia. The main treatment for prostate cancer, some of the milder cases, sometimes we monitor and we don't do anything. We just change the lifestyle. Maybe we just drink less water at night so we don't wake up so often. But some patients, we actually need to give medication. And these two groups of medication are more common currently. One is called the alpha blocker. Second is called the 5-alpha reductase inhibitor. As we all know, the first group of medicine called alpha blocker simply relaxes the prostate to make the urine flow go smoother. But this does not change the size of the prostate. The second group of medicine called 5-alpha reductase inhibitor, they actually reduce the size and make the prostate smaller. When the prostate gets smaller, it's easier for the urine to flow out. This two medicine has been used for a long time. And one of the big studies called MTOPS, the Medical Therapy of Prostate Symptoms Study, this was published actually in 2003, about 18 years ago, that says medication can help the symptoms of BPH. However, what is the problem? After all these years of using, we found that actually these two groups of medicine, although it's effective, but it can cause a lot of side effects. Some of the long-term side effects, as you see here, for alpha blocker includes headache, fatigue, and actually the ejaculation for men become less. So the sex function become much less as well. And this medicine, unfortunately, we have to take forever. The problem is new side effect we found. Number one, it can cause increased chance of stroke. Second, this medicine can cause dementia. So unfortunately, you can pass urine, but you forget what's happening. You know, you can't really have sexual intercourse, the ejaculation become worse, and also higher chance of dementia. How about the 5-ARI medication that used to shrink the prostate? It has a lot more ejaculation problem. It causes impotence, erection is not so good, reduced libido, and sometimes it can cause breasts to form in men. The worst thing is the new side effect that we find out is actually increase in metabolic syndrome, and it causes obesity or even some of the diabetes or heart problem in the future if we keep taking 5-ARI. And also this medication causes dementia in the long term. So unfortunately, this medicine need to take long term, and we know that the longer we take, we have this medical potential side effect. So is there anything else we can do? In the past, if people cannot take medication anymore, we do an operation called transurethral resection of prostate. Simply do a surgery to remove the blockage of the prostate. That is the traditional way that we remove prostate tissue. That's number one. There are so many ways in the world. A lot of urologists will know that there are lasers, there are different kind of removing types of laser, whatever way to reduce the size of the prostate. Of course, there's another way. Number two is to heat or burn the prostate tissue. We can always use microwave. We can use needle ablation, different types. Or third way is to simply open the prostate. It's called a prostate stent. Not many people in Singapore use it because of some of the side effects we find. So these are the three possible ways of doing when we treat the BPH. So let me try to show you what are the possible ways. There are actually a few ways that are actually less invasive procedure compared to the more invasive surgery. Three of them, I'm going to introduce what we have actually in Singapore. The less invasive treatment include ProLift. This uses microwave energy. Second is Resume, uses steam energy. And third, Urolift, the suture implant. I will continue to share these three in the next few slides. First is ProLeaf. ProLeaf is actually a machine that you see there. We have it in Farrer Park Hospital. What we do is we simply put a urine catheter into where the prostate is. If you look at the picture, the prostate is enlarged and blocking the outflow of the prostate. This ProLeaf machine simply inserts a urine catheter into the bladder, and there's actually a thermodilation balloon. So the balloon itself sits exactly at where the prostate is. It heats up the area of the prostate and causes necrosis, and this uses a microwave treatment. There's a temperature probe at the anus, at the rectum area, so to make sure the rectum does not get overheated and damage the rectum. So there's a temperature probe in the rectum. This is how we measure, and we know the difference in the temperature that can actually be heated up. And usually the average temperature of the prostate will reach 51.8 degrees Celsius. And this takes about 45 minutes, and the patient goes home. If they come for before breakfast, they go home at lunchtime on the same day for this procedure. Let me talk about the second way of treating prostate enlargement. Second is you don't use a microwave, but you use a steam. This is called the Resume. The Resume, this is just the instrument of the system. It's actually a handheld delivery device, and there's a generator for steam. What happened is, I'm going to show a video here. There's no sound to it. So, are you able to see the video, Farzana? Okay. So
Yes.
okay, thanks. So there's a catheter that goes in, and the left-hand side is the actual operation now. There's a needle that will be going into the prostate on the side. You'll see a white needle going in. It delivers steam into the prostate cells. It's only 9 seconds. If you look at the left-hand screen, 9 seconds of treatment, done. Actually, the treatment is done while I'm talking. We are done, finished. And then we move 1 centimeter away from it and continue to the next area to put steam energy. So we do it every 1 centimeter apart, depending, of course, on the size of the prostate. The bigger the prostate, the more needle marks we have to put. But every single time we put a needle in, actually, now the needle is in, you count 9 seconds, and the treatment is done. The steam go to 100 degrees Celsius. The way you cook, you cook eggs in your kitchen is the same, 100 degrees. You will cook, actually, the steam will cook the prostate cells, and it will cause necrosis in the next couple of weeks, and the cells of the prostate will slough off itself. And that is the surgery. So if you look at this whole video, is only about 2 minutes and 30 seconds. After that, patient wake up and go home. And this is the end of the treatment. Finish and patient go home. So that's exactly the full treatment. The patient will have woken up after this and go home before I even finish my talk. What is important to know about Resume? Resume causes a thermal lesion along the prostate urethra using steam energy, by the way you saw it. The aim is to make sure we remove the bulk of the adenoma, prostate adenoma swelling just next to it. So this is also a day surgery procedure. If you come in the morning, you are discharged to go home at lunchtime. And this is the way we design and know how many needle marks we need to put depending on the size and length of the prostate urethra. And after treatment, this is a 5-year study that they have. And after 5 years, 95.6% do not need any more treatment. So only 4.4% of patients have to do another treatment again. So most patients are cured with this alone. And this has the lowest amount of repeat treatment compared to many other systems. So let me talk about the third system that is possible. It's called UroLift. Some patients do not like to have microwave energy. Some of them do not like to have steam. Because as you know, for example, steam, it will cause swelling, edema. And actually, patients need to be on urine catheter after the treatment. So not many patients in Singapore like to have urine catheter. Although the steam energy delivers well, but not everyone likes to carry a urine bag in Singapore. So there's another option called UroLift. And this is using a suture implant. It is called UroLift. And UroLift has been around for more than 10 years. The simple way to describe it is we put a cystoscope into the bladder and prostate area. When we see it, we simply open the channel. So it's like at your house, you have a window with a curtain. All you do is open the curtain. You can see the picture outside very nicely. So all we do is open the prostate channel and put the implant in. If I can show you the video, this one has sound.
The UroLift system is a proven minimally invasive technology designed to relieve urinary symptoms and improve quality of life with minimal side effects for men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH. The UroLift system procedure begins by inserting an implant delivery device into the urethra. An attached endoscope provides visibility to the obstructive prostate. On reaching the area blocked by the enlarged prostate, the obstructive prostate tissue is moved aside. Following a trigger press, the device inserts a fine 19-gauge hollow needle across the prostate and deploys the implant through the needle. The implant is a nylon suture fixed in place with a thin metal tab at each end. Depending on the prostate size and blockage severity, the doctor inserts several more implants the same way. Typically, 4 to 6 implants are placed into the prostate. The outer capsule of the prostate is firm and provides a solid anchor, which allows the implants to lift and hold the enlarged prostate tissue out of the way so it no longer blocks the urethra. As the sutures are shorter than the prostate depth, the prostate laterally compresses. This reduces pressure on the urethra and provides immediate visible results so urine can flow freely. It's a mechanical solution to a mechanical problem. The minimally invasive procedure requires no cutting, heating, or tissue removal. This procedure avoids erectile and ejaculatory dysfunction. It typically also means minimal downtime, mild to moderate side effects, and a quick return to normal activity. The UroLift system provides a clinically proven treatment for those who suffer from an enlarged prostate that can get men off BPH medications and avoid major surgery.
So the UroLift simply remove and it's like opening a curtain, and it's exactly the same day surgery procedure. You come in the morning and you go home for lunch. So these 3 procedures all can do the same. Each of them have the good points and bad points of each. So you have to discuss with a doctor which one is better for you. For UroLift itself, it has a lot of clinical research paper for the last 10 years and in very good journals, including BJUI and EAU and all the different articles you can actually find out. In addition, UroLift system is the only medication that doesn't cause impotence, it doesn't cause ejaculation problem, it doesn't cause ejaculatory dysfunction. And this is suitable for men who still want to have sex, normal sensation, and the sperm doesn't have any retrograde ejaculation. So it's very rare. Prof. Salam will also probably say the same thing. It's very rare for any research to say that 0% of side effect. And this one actually shows in multiple centers is 0, no side effects for erection or ejaculation problem. And this is, it works faster than TRP because immediately when patient go home on the same day, they can pee immediately on the same day. And the effects is long lasting as well. So this is the end of my talk for the new less invasive treatment for enlarged prostate. In summary, ProLift gives microwave energy, Resume gives steam energy, and UroLift is a suture implant. All 3 of them have its good points and bad points, depending on the size of the prostate, the nature, whether a patient wants to have sexual intercourse, do they still want to have any other, if you want a urine catheter, and so those are some things we consider when I'm going to decide to tell patient which one is better. So that is the end of the talk for BPH. Let me go on to the next new treatment for prostate cancer as well. And at the end of my talk, I'll take a question and answers. Prostate cancer, as we know, the cancer treatment depends on whether it's an early stage cancer or a late stage cancer. Early stage cancer, like what the Prof. Salam has said, we see more and more now, and we try to cure patients. But however, when it's late stage, we have to go to different systemic treatment. There are also new treatment called selected options for only some patients. Not everyone is suitable. And I'm going to talk a little bit about HIFU as well. For early stage prostate cancer, we know the traditional way to do surgery is to remove the prostate. In the past, we used to do an open surgery, make a cut in the abdomen area below the belly button to remove the prostate. We advanced to do keyhole surgery called laparoscopic. And in Singapore, we are fortunate to have the intuitive Da Vinci robotic system to do our prostate cancer surgery. So this is one of my pictures when I was training in New York City. So I was working there, and Prof. Salam knows Dr. Peter Scardino. I am in the middle of the surgery, holding the instrument, and Dr. Peter Scardino is next to me, telling me and guiding me when I do surgery. We do about 20 operations every week. So I do 3 operations with him every single day when he do a prostate cancer surgery. For Da Vinci robot, I can only do 2 operations a day because the setup is a bit longer. So that's the position I am. That is the Da Vinci robotic SI system when I was in New York City. So we do that as well using the open and Da Vinci system. The other patients sometimes go for radiotherapy to treat prostate cancer. Patients will lie onto a radiotherapy machine, and this can be used for both localized and locally advanced cancer, and also sometimes for painful bone metastases that spread to the bone. So this is also available for treatment. However, we all know no matter how good a surgeon is or how good a radiotherapy machine is, we do get some side effects from our treatment. If you look on the left-hand column for radical prostatectomy, every surgery will have some blood loss. There's some anesthetic potential risk. Every patient will get urine incontinence, and everyone will have a chance of getting erection dysfunction, impotence. However, if they go to choose radiotherapy, they may also have urine incontinence or erectile dysfunction, but there are also other complications like urine frequency, and at night they go to toilet. Sometimes there's bleeding also in the bladder or rectal area. And unfortunately, another cancer can happen because radiotherapy in the past can also accidentally shine on the area of the bladder and colon and cause another cancer after that. Although the machines now are better, but in the past that can happen. So patients will ask, how come I must go for such a difficult surgery or radiotherapy and still have side effect? Are there other options? Yes, it's possible. So some of the selected options include HIFU, which is high intensity focused ultrasound. What does it do? HIFU simply means focusing ultrasound onto an area. If you remember when we are young, sometimes we take a magnifying glass and then we try to burn a leaf in the forest, right? So the magnifying glass will focus the sunlight onto the point of the paper and it burns. So you know the sunlight won't burn the paper, but if you focus everything into one small tiny point, you'll burn. So this is the same principle of HIFU. The ultrasound is no harm, doesn't cause any problem. But if we focus all the lens, the ultrasound lens onto a point, it get heated up. So the heated up point at the point goes to 85 degrees Celsius. So it actually can kill off all the cancer cells that is in the focus. And if you look at the slide below, it actually shows the ablated tissue with all the cancer cells being dead after 14 days. That's called fibrosis. How do we do focal therapy? Now, we are very fortunate to do MRI of the prostate in Singapore. And when we do the biopsy, we actually can tell exactly where is the prostate cancer cell. Is it the right-hand side on the upper part, the lower part, the left hand, right hand, how many areas of prostate cancer there are. So once we know where's the prostate cancer, it's like when you're driving on a road, it's like GPS. I know exactly where the cancer cells are hiding. So we can actually use the HIFU to focus on only cancer area. All the other areas that do not have cancer, we do not treat it. So we can sometimes avoid the neurovascular bundle, which means that if cancer is not near there, we save the nerve and patients still have erection and have sex after prostate cancer focal therapy treatment. How do we decide to buy this machine and get this into Singapore? And it is in Farrer Park Hospital. That's because this company called EDAP TMS has many machines for ultrasound to do HIFU, many years. But this particular new machine called Focal One has been approved by US FDA in June 2018 for surgical removal of prostate tissue. And if you look at the last line, they lessen the damage to healthy tissue to minimize side effect. So when this came out, Farrer Park Hospital decided to have this, and we have this machine now in Farrer Park Hospital. And this is the Focal One machine, all in one procedure can be done through this. This is the machine. Patients sometimes ask, oh, are there any research paper? So if you look at it, there are lots and lots of research papers, over 90 peer-reviewed publications for localized prostate cancer. Is it a long term? Yeah, there are papers, there are 14 years follow-up, 15-year follow-up, 70-year follow-up. And we know that for prostate cancer in early stage, we sometimes need to follow 10, 15 years, and they do have. And for the cancer survival, is much higher when it's a low-risk cancer. Up to 99, 100% of patients all get cured from this HIFU treatment. And how about if we do focal therapy alone? That means don't treat the whole prostate. Focal therapy is multiple research papers, even in European urology, which is some of the papers that we read for urologists. And the latest one, which is a multi-center 5-year follow-up outcome after focal therapy. This is research done in London, University College London, and some of the other hospitals in UK. They look at 625 patients. They use another machine called Sonoblade, but it's also a HIFU machine, to do a 5-year HIFU outcome. Every single patient survived from cancer. 88% of patients do not need any more treatment. Only one focal therapy is enough. And amazingly, they found 98% of patients do not even leak a single drop of urine. As you remember just now, if you do a radical prostatectomy, all my patients wear diapers straight after surgery, 100% all wear. And when I tell them 98 do not wear, they do not believe it. 98% actually do not have. And the remaining 2% sometimes only use 1 diapers a day. That's it. So this is a 5-year outcome for this study from UK. Does it mean everyone should do focal therapy? No, that's not true. Because although there are advantages, there are disadvantages as well. We know that focal therapy will reduce the chance of erection problem and urine leak. If the cancer cells is in half the prostate, we have to do hemi-ablation, called half of it. It can sometimes cause the side effect, but it's actually reduced compared to open or robotic prostate surgery. What's the disadvantage? Since we are only treating part of the prostate, sometimes at 5 years, there's higher chance of recurrence compared to when we do radical prostatectomy. Why? Number one, sometimes when we do prostate biopsy, we miss cancer that are between the biopsy course. And we unfortunately cannot solve this problem at the moment. We know that some cancers can be missed due to prostate biopsy. So up to 10-20% can recur. What happens if patient recur? Oh, they do another HIFU in 5 years. Or they can say, okay, I don't want any more HIFU. I just go ahead with the usual radical prostatectomy or the usual radiotherapy if the cancer recur. Some of my patients ask me, oh, doctor, I had radiotherapy before. My prostate is still in the body, but the doctor said after radiotherapy, the prostate cancer come back. Yes, you can still use HIFU as part of a salvage focal therapy treatment rather than do a surgery. So this is possible to be done. Of course, there are some patients after radiotherapy who has a spread of the cancer to the bones or elsewhere. Unfortunately, we cannot use HIFU. That one require hormone treatment, chemo, or in Singapore, we are going to start the lutetium-177, especially after the latest research from ASCO. So how about radiotherapy recurrence? So these are some of the papers who had for patients who had radiotherapy in the past, cancer come back, and we treat with HIFU. So it's pretty good data. And when you look at the systemic review of all the salvage focal therapy for patients who had radiotherapy in the past and cancer come back, if you look at the data, 86% are biochemical disease-free, and short-term 3 years, 65% are still biochemical disease-free survival. Pretty good. I would say since the patient have cancer that come back, we do not cause major side effect for them, just a focal treatment just to get them to have better quality of life in the future. So in summary, focal therapy machine, this is we have the Focal 1 machine, which is the latest machine. There are many HIFU machines for prostate cancer. You probably can read online, but this is the latest one, and this is the one approved by US FDA, and it's in Farrer Park Hospital. It is using a robotic assisted. I can tell the machine exactly which area of prostate to treat. It uses HIFU, means that there's no cutting, no radiation, no surgical wound, no surgical scar. And this HIFU for focal therapy can be used for cancer that's within the prostate, called localized cancer, and also recurrent cancer for patients who had previous radiotherapy. So that's the end of my talk, and this is the overview of what I've done in this short time. The treatment of enlarged prostate that's benign, we talk about ProLift, Resume, and UroLift, all using different ways of enlarging the prostate channel and useful with different profile, good and bad points. For the treatment of prostate cancer, we know that for selected patients, we can use Focal 1 to treat patients. For patients who have localized cancer within prostate, and also patients who have cancer that come back after radiotherapy. With that, I thank you for your invitation to share some of my slides. And this is how you can reach me, and I can take questions from now. And thank you very much, because I want to always thank Farrer Park for letting me have a chance to talk about this. And these slides I want to show you. So if there's any other question, you can also contact Farrer Park or Mr. Hassan. His contact number is there for more information about Farrer Park Hospital. Thank you very much.
Thank you so much. It's a huge information, advanced treatment options in Singapore. You already covered everything there. So when you were just focusing on these things, I had a question in my mind that usually this disease is related to age. When an aged person is suffering from multiple other complications, so how risky is for him to go for the surgery or any procedure?
So that's one of the things that all of us as surgeons have to assess, the what we call the comorbidity of the patient. How safe is it for us to do certain treatment, and especially for surgery, are they able to do general anesthesia? Are they able to do spinal or sedation? So if you talk about the enlarged prostate, the BPH, I can tell you that the ProLift, we use a local anesthesia. Patient do not have anesthesia. We just put the jelly, the local anesthesia lignocaine gel that we normally put for urine catheter. We put it in, and that's the anesthesia. That's it. And patient are talking to us, and after that they say, "Oh, it's done." Then they go home. As for Resume and also for UroLift, they do not need general anesthesia. They do not need spinal anesthesia. They just have a sedation. So we just give them a sedative like diazepam or something, and operation is over in 10 minutes. And they go home after that. So that's for the BPH treatment. As for the HIFU treatment is done under, usually it's about 1 hour to 2 hours, depending on the size of the prostate cancer. They are in Singapore, we are doing under general anesthesia because I do not want the rectal probe to move. And we always worry about rectal injury, right? That we'll be very worried about. So in Singapore, we do under general anesthesia. In Europe, when I visit people in France, they do under sedation or spinal anesthesia, and patients are just chit-chatting with the surgeon. So I don't feel comfortable yet. So I rather use a general anesthesia, so everything is fixed, and then I can control the directions of the HIFU. That's my personal experience.
Thank you so much, sir. It's really informative. Now I'd like to request Dr. Professor Salam, sir, to discuss about actually this is all about the advanced treatment options that Dr. Chong actually focused on. But people wants to know that what is the actual reason behind this prostate cancer? Is that related to their lifestyle, food habit, or is there any chances that anyone having a prostate enlargement later on it becomes a prostate cancer? Please, sir. Sir, can you please unmute? Yeah, sir, can you please unmute?
I forget to do that all time.
Sir, unmute, sir.
Can you hear
Yes.
me now? Okay. Thank you very much for this nice question. Many times we are confronting with this situation that BPH is going to convert itself into prostate cancer or not. I would have to tell you that these two diseases are entirely different. They do not have any relations. So they are isolated disease and they should be treated isolatedly. Many times they are concomitantly they can be found in a particular patient. So they are different. So one treatment is not going to interfere is not going to treat the other condition. So both has to be addressed in a different format. But the prostate cancer is a life-threatening disease. If it is not treated properly, the patient may end up with his life with this disease. So one should be very, very careful. And the BPH is very common. Many patients do have problem. Every patient do not have to submit themselves for intervention. And in my practice, we have seen in our in one of our research that about 10% of the BPH patient they need intervention. So 90% of the patient they can manage to survive without any intervention, means without any surgery. They can have lifestyle modification, lowering the limit of the water, early dinner, which become very helpful for the nocturia and the other frequency, urgency, etc., etc. Many times the drugs are available, they are helpful, and when they are not, then question of intervention comes. Many intervention comes over the centuries, and many disappears. And the standard treatment, if you say like that, the transurethral resection of prostate, still it is the gold standard. And that was introduced in about 1923, about 100 years old. This is very interesting. This surgery is still existing with its all glorious and marvelous work. And the treatment which Dr. Chong has explained, all these are very interesting, and this is nice to work with it. But time will only say whether which one will stay. Many technology which has come in the form of, say, for example, stent. In 1990s, the prosthetic stent became a fashion. Most of the centers were offering the prosthetic stent. It is a mammothérmic stent. This is highly expensive. It's about $700 or $800, the stent, and they are being inserted into the prostate, and they expand and keep the expanding lobe of the prostate away so that the patient can pass urine. But very soon we understood that migration of the stent, incrustation of the stent, then various complications related to stent overrules the advantage. So it was dropped from the urological treatment list. Again, this microwave therapy was introduced in 1990s with a great promise. And nowadays, a different type of microwave is coming, as Professor Chong has explained to you. But in 1990s, they disappeared. But they came with a big promise that you don't need to do anything. You just lie on this bed, and you will have microwave therapies. And like the food will cook the prostate, unnecessary part or which is obstructing pathological, you will treat it and you will be fine. But with time, we can understand that it's not very much effective. However, the Urolift and the steam treatment of the prostate is still on, but it is the time which will say to us what will happen with this technology to the BPH patient. But compared to that, we consider that standard transurethral resection of prostate is also a minimally invasive but very effective treatment. That comes as a last part of the at the last resort. However, the new technology has got promise, and in right hands, like Dr. Chong, I believe that this will do very well. So this is about the BPH, and for the cancer therapy, for the prostate cancer, it's very interesting to note that he has covered almost everything. But I am very pleased to see that the focal therapy, and I would like to inform you that the maximum research on focal therapy is being done by the Imperial College of London. And the man behind this research is Professor Hashim IMIC. And you will find so many references regarding this focal therapy with focused ultrasound. And he is very optimistic. I had a lot of conversation with him. He smiled only. He didn't say anything. He said that it is the time which will say that this is a good treatment or not. But he is not unhappy. He is quite happy. And if it is available with Professor Chong, I believe that this is going to help the patient who have got a organ confined intermediate or low risk prostate cancer. Certainly, they will be very, very benefited. Uh, we have not told about the Saigon knife therapy. Currently, Saigon knife therapy is becoming more popular in the US. I don't know what is happening in the Singapore. People who do not like surgery, they submit themselves for radiation, and radiations, where varieties of radiation treatment are available. Those are also minimally invasive, like HDR. They put some radioactive seeds, and also they put IMRT or IGRT with a curative intent. Then one can have a proton therapy. Possibly the National Cancer Center in Singapore has got a proton therapy center by this time, I believe. Uh, in India, we have got a proton therapy center in Chennai Apollo Hospital. So that has also some promise. But these all are new treatment. It is the time which will say that which one will stay and which will disappear from the treatment list. But it is always nice to welcome the treatment, and I believe that in good hands, always the new treatment may do extraordinary work. I appreciate the talk of Professor Dr. Chong, and I welcome his presentation very much.
So
Thank you,
actually,
Prof.
thank you, sir. It's a huge area to discuss. I think hours and hours it can be discussed, and people may want to know more and more. Like right now, we are having lots of questions. Like one question we already got, that what causes prostate enlargement or prostate cancer? Is it genetic or lifestyle related?
Very
Uh,
important.
yes. So,
People believe
Professor,
that
you
prostate
want
cancer is
to?
genetic disease nowadays, and genetic transformation is one of the very important cause for the high risk prostate cancer. And when anybody is branded as high risk prostate cancer, their family has to be screened. Their sons, their brothers are likely to have this disease if they have got BRCA1, BRCA2 positive. And other genomic tests, when they become positive, then certainly they should be screened very carefully. So this is a very important message. BPH is also familial disease. Professor Chung, would you agree to that?
Chong, would you like to? Yes. Dr. Chong, would you like to add something with Professor Salam?
So I agree with Prof. Salam. New research are also finding out that prostate diseases pass in a family, especially the NCCN guideline now says that when patients have castrate-resistant prostate cancer, we need to actually do a genetic family study. In Singapore, it's very difficult. We do not have a lot of genetic counselors. And as urologists, we don't really have a lot of, at least in Singapore, our training is not so good in finding out every single genetic counseling skill. So our trainees are still finding difficult. So we are trying hard to figure out how. But I think the basic guideline is if you have a family member who has prostate cancer, especially your father's side, which means your father, your uncles, or the father's side, we also need to go and talk to a doctor and find out whether you could have prostate cancer. What is interesting is that, like what Prof. Salam is saying, there's a BRCA1, BRCA2 gene, which is actually a breast cancer gene. And now we have some research to show that even the mother's side who has breast cancer can pass it to a man, to a son. And then this can also cause a higher risk. So Prof is very right. But at least in Singapore, we are struggling of how to do genetic counseling. But my basic instruction to all my patients is, if you have a family member who has, please see a urologist like Prof. Salam to discuss what's the risk and find out. Do at least a blood test called PSA at the earlier stage. So that's what we know.
What is the normal actually PSA level for a man not having prostate cancer?
Every man will have prostate when we are growing up, and when we grow older, prostate will get enlarged because of our testosterone effect, and every man will have a bigger size prostate. In the past, we used to have an age-specific PSA. In Singapore, we find that our research in Singapore shows that it doesn't really flow in Singapore. Nowadays, we are also looking at the studies from US. We are also looking to use this test called Prostate Health Index. This actually helped us a little bit to understand whether the higher PSA is likely due to cancer or not cancer. So we have done some research and show that even at PSA of 3, still possible to have cancer in Singapore men, but the risk of this cancer is actually a low risk Gleason 6 cancer. So I'm not sure about the data in Bangladesh, but Singapore, that's what we find. Our laboratory says in the past is 4 and below is no cancer, but that's not true. We find that even lower than that 3, PSA at 3, also we do have cancer in our research.
Actually, in our country, we take a cutoff level at 4, but when we personally see or evaluate the patient, we take 2.5 or 3. When the patient is exhibiting a 2.5, we consider that this man is suspicious of having a prostate cancer or will have a prostate cancer in later part of his life. So we warn them that your PSA level is higher. May not be 4, but it is still you are on the risk. And I would have to tell you that about 15% patient will present with prostate cancer with less than 1 serum PSA. So that has to be borne in mind.
Okay.
Many patients
so, sir,
are.
Though we are discussing about prostate cancer, but we got another question from a woman that what is the common cause of recurrent urinary tract infection in women, and what is the consequences if it is not being treated?
Dr. Chong, you can address this.
It's a normal urological concern.
They need to have an international opinion. Certainly, they have many doctors here.
Right. Urine tract infection is more common in women compared to men because of the urine tract that reaches outside of the body, they call it the urethra, is shorter. So there's a higher chance. And at least in Singapore, we know that we give patients up to 2-3 urine infection per year, and then we treat them by giving antibiotics. But for men, it's a bit different. So for men, if they have 1 infection only, we always want to find whether there's an anatomical, that means a structural area that's not so good. So that's the difference in men and women. So I understand the question is for women, right? So for women, first see in Singapore we will see a general practitioner, but if it gets too often, maybe 3 or 4 a year, see a specialist. A few things we look for women. Number one, do you actually empty your bladder completely? Number two, during sexual intercourse, is there possibility of contamination? And number three, are there patients who are menopausal and then they have what we call vaginitis, dry area in the private area? So these things, when it's too frequent and bothers you too much, please see a urologist, an experienced urologist, to find out the possible cause of recurrent urine infection.
Okay. So another question I'm just taking from a patient that how can we prevent from PUG obstruction? How much cost of PUG obstruction in obstruction surgery? So would you like to?
Let me
Yeah,
answer this one. This is
yes.
absolutely unrelated to this to the subject of this webinar. And PUC obstruction means pelvic ureteric junction obstruction. It is a congenital defect that happens in the kidney. The outlet of the kidney is having a narrow segment of area which prevents in normal flow of the urine from kidney into the bladder, and that causes the hydronephrosis, means the kidney becomes swollen and it has become waterlogged. Surgery is the best answer for this. Here again, minimally invasive surgery was done in different format in 90s, 2000, etc., etc. Nowadays, it has been concluded that it is the surgical reconstruction of the narrowed segment is the best option, and that can be done by laparoscopic or robotic surgery, and the cost is very small, even in this country.
Thank you, sir. Thank you so much for your information, valuable information. I have a question to Dr. Professor Chong. Recently, he had operated a patient very successfully with a kidney cancer. So my question is that necessary that someone having kidney cancer to remove the whole kidney, or it can be saved with other treatment?
Thank you for your question. Kidney cancer is we have learned a lot from the past, where in the past we find too much operation. Kidney cancer do not occupy the entire kidney. It's like having a chapati. You eat chapati there, right? If a little bit of it is not so good, you just tear out the part that's no good and keep the rest. So it's something like if the kidney tumor can be removed without removing the whole kidney, we do it. It's called partial nephrectomy. But you need an experienced surgeon who can tell you whether it's possible to save the kidney to do reconstruction, whether you can reconstruct the urine system called the pelvic calyceal system, and whether it's too near the blood vessels we call the renal hilum. So these things we have to look at it. If possible to save as much kidney as possible, we'll do it. It's called partial nephrectomy. You can do it very well with open surgery. You can do it very well with laparoscopic surgery. You can also do it very well with Da Vinci robotic. But the principle is the same. Save the kidney, prevent future kidney failure. And that's the best thing. The most important is choose the surgeon who can assess and discuss with you. So we do not remove all the kidney completely at this moment. We only try to do partial nephrectomy. Now, Prof, any comments?
Oh, this is a very interesting area for myself. We have been embarking on these subjects in T2 cases. T2 means it is fairly big tumors. We have been treating with partial nephrectomy as a part of our research work. And we found that about 10% of the patients, they come back with positive margin and also recurrence. So T1 is a very safe indication. T1 means less than 7 centimeter tumor, and when the renal score is minimum, then it becomes easier for the surgeon, and when the renal score is higher, then obviously it becomes difficult for the surgeon. And for difficult cases, maybe open operation could be a very good and safe procedure. And
So,
we are
sir,
looking executing one.
okay, I will pick just two more questions. The very common question is that preserving sexual function after prostate cancer, and what to expect during regarding sperm count and all that. Dr.
You can make
Chong,
up Dr.
would you
Kian.
like to
People would
discuss
like
and then
to have an answer from you. I can supplement if it is needed.
yes.
Okay, thanks, Prof. Thanks, Prof. Salam. So prostate cancer treatment depends firstly the aggressiveness of the cancer, the stage of the cancer, whether it's an early stage or late stage, or what is the location of the cancer. So the traditional way of treating it is to treat the entire prostate gland, be it by surgery to remove the whole thing or by radiotherapy. We know that if you are worried about sexual function, the important areas for us is actually the nerve for erection, which is at 5 o'clock and 7 o'clock of the prostate gland. If we do surgery, there are ways that we can try to preserve the nerve, but sometimes may not be possible to preserve every nerve. So some nerve will actually be removed. And second way, if you do radiotherapy, they can try to reduce the chance of damage to the neurovascular area. So in Singapore, a lot of them are doing a stereotactic radiotherapy, SBRT, or other newer ways of IMRT. But whatever it is, when you treat the whole gland, there's a chance to damage the nerve on the right side and left side, there are two. However, if you actually choose to do focal therapy, you might be only able to do one side while the other side is completely not damaged. So there's a chance, much better chance to have erection. However, I tell every patient who have a prostate cancer that they should expect some form of side effect. Because if I tell patient they'll be completely no side effect, that's not real, that's not true. But at least I tell patient what are the potential ones, and it may be worse or may be better, but at least tell them the options and the treatment. So this is one thing about the erection issue for prostate cancer treatment. The other way is if patient have late stage cancer metastatic disease that has spread to the liver, lung, or bone. Unfortunately, the treatment we give also causes a problem with sexual function, because like hormone therapy that we actually use for patients can cause the reduce in libido and reduce in sexual drive and impotence. So that's something we are still not able to bridge at the moment. Some patients I give Viagra and give hormone treatment as well, but they still don't feel so well. So I'm not sure whether Prof. Salam have other ways of treating such metastatic prostate cancer patient when they still want to have sexual intercourse. This is a difficult problem that I find.
I think you have covered most of the areas. I can supplement by saying that the patient who are having metastatic prostate cancer is going to, we will be treating adequately with hormone treatment, radiation treatment, or whatever it may be. They will just going to destroy or interrupt their sexual function by all means, and their libido will be reduced, their activity will be reduced, and they will not respond to normal PD5 inhibitor. Most of the time, the response is only with alprostadil self-injections, intracavernosal self-injections, level 2 treatment. Some of the patients who are really very responded very good, they can go for third-line treatment, means penile implants, if they wish. These are the final outcome, and with penile implant, the peoples are relatively happy.
Thank you so much, sir. So I'm just picking the last question from the audience that does prostate enlargement have an issue with erectile function for a man? Professor Salam.
Erectile function is not expected to happen if they are being treated with minimally invasive treatment. And with TURP, we have estimated that our data indicate that it's about 15% of the patient, they have transient dysfunction of erectile function, and almost everyone will have about 80% will have retrograde ejaculation or dry ejaculation. So this is the outcome.
Thank you so much, both the doctors. This is my last and final question to you: that what should be the lifestyle to avoid this disease, and the patient who is suffering from this disease, what should be his lifestyle? Uh, I would like to start with Dr. Chong Kian, and then Professor Salam. Then we will end our session. Dr. Chong.
If I hear correctly, your question is how to reduce the effects of having enlarged prostate. Prostate that's enlarging is a common thing for all men. We always, and being a man is a risk for us to get BPH. I tell my patients, you can't stop getting BPH because being a man, you might get it. But what's more important is find out the symptoms that BPH can occur and see a doctor early. Majority of the patients actually just need to change their lifestyle. I agree with Prof completely. Most of my patients, I tell them, don't see me. Please just drink less in the night, or get a healthier lifestyle, eat more healthy. In Singapore, Chinese men are difficult to manage for BPH because Chinese men, we like to drink soup at night, and the wife will cook a lot of soup. So we keep drinking, but keep waking up at night. So I cannot tell the wife not to cook. So that's a challenge for us. Lifestyle changes is reduce fluid intake at night, and also reduce any food product that can irritate, like coffee or tea. In Chinese dinners, I don't know whether you know, we have to drink Chinese tea, and we keep waking up at night. So Prof is right. Change lifestyle. That's the first thing. After that, if you still have problems, see a doctor.
We have got the same problem. Our general people have got a belief that more intake of water or drinks will flush the kidney, and this is a very common affair with the commonly believed by the general people, and they used to drink a lot. Many times we have found that about people are drinking about 10 liters of fluid a day, and they develop GI symptoms, nausea, vomiting, etc., in certain cases. But we try to optimize the water intake, asking them, you try to limit by 1.5 liter approximately, and have an early dinner, and no drinks after dinner. That will help you to not to get up from the bed. So this is important lifestyle change, but at the same time, the patient should see his urologist nearby, or a general practitioner who will expect to do a digital rectal examination, at least to exclude any abnormalities in the feeling of prostate, so that he can diagnose early prostate cancer. That is important.
So when is the right time for the screening?
Yes.
When is the right time for the screening? What is the right age?
If the patient do not have any prostate cancer member in the family, then maybe 50 years may be good. But if they have got a member who has got a prostate cancer in his family, from 40 years he should do it.
We do the same in Singapore, just like what Prof. Salam says.
Okay. So thank you so much, sir. This is a huge area, and you both are more experienced, and I feel that lots of questions coming from me also, and here the audiences are going on with lots of questions. So definitely, I'm feeling that we should continue this session in our later on in any webinar. Definitely we will do, and we will be honored with your presence. Thank you for your presence, and আপনারা যারা শুনছেন, আপনাদের যদি কোনো কোয়েরিজ থাকে আমাদের ফেসবুক পেজে আপনারা কোশ্চেন করতে পারেন। আমরা আমাদের ডক্টরদের কাছ থেকে সেগুলো আনসার দেওয়ার চেষ্টা করব। আর এই করোনা সিচুয়েশনে আপনারা প্লিজ সেফ থাকেন, বাসায় থাকেন, মাস্ক ইউজ করেন, যতটা আসলে ডিজিজ থেকে দূরে থাকা যায়। Thank you so much, doctors, for your time, and we are extremely honored, and it was really informative. Thank you.
You are most welcome, and we feel honored.
Thank
Yeah,
you, sir.
thank you very much. Thanks,
Thank you.
thanks, Prof, for your advice.